we're not at the point where anybody, any organization, any person should be saying, okay, we're done. We're just going to go back to the way we were in summer of 2019.
Welcome to the RANE Insights podcast. I'm Emily Donahue. Let's listen as RANE founder David Lawrence speaks with Drs. Fred Southwick and Bill Lang for our weekly coronavirus update.
Bill and Fred, once again, thanks for joining the podcast and helping us understand the data, the information, and what we should be doing. What's coming up, per our conversations before this podcast, is even though numbers look good, hospitalization rates look good, employers are still struggling to bring their workers back, and everybody has noticed that people are still getting sick, and maybe you can provide some perspective on that.
Well, David, that's exactly what I'm seeing with the organizations I'm working with also, is that the official numbers are down to slightly up. New York City actually has seen almost a doubling in cases, but that's a doubling from a very low level to a still low level, but higher. But even at those low levels, people say they're seeing more cases anecdotally in their workplaces and their communities than they saw when the case levels were measured to be real high, even just a month and a half ago. And what's really happening, I believe, and I think the data supports this also, is that people aren't getting that sick with the new variants, with BA2 specifically. Now that's because of changes in the virus itself, that it doesn't affect people in the same way, but it's also because we do have this, if you want to call it, degree of herd immunity. We do have so many people in the community who are relatively immune, either by vaccination or by having had one or more exposures to COVID in the past. And so then what's happening is these people aren't sick. So if they even bother to test, they're not reporting it because they're not needing to go into any kind of center where it would get reported automatically. So the numbers are not down quite as far as they would appear to be, but that's because it isn't having anywhere near the effect that it used to have.
The BA2 is 30% more infectious than the BA1. And I actually heard about a super spreader event at a wedding just this last Saturday, and by Monday, a high percentage of those that attended did become infected. But it's relatively mild, and virtually everyone that was at the wedding had been vaccinated and or had a Delta or Omicron. It appears that Delta, if you had infection with Delta, that doesn't seem to be quite as protective as if you had Omicron. But the degree of severity is definitely lower. I think predominantly because so many people have some immunity, may not complete, but they have some.
And in fact, Fred, you were reciting an amazing statistic for your hospital over the last couple of weeks.
Yes, as of yesterday, we had a single case of COVID in our hospital on the hospital service where we had 80 to 90 during the peak of Omicron. So this is dramatic. I'm waiting for zero. It should be in the next day or two. But clearly the hospitalizations have dramatically decreased.
And deaths also.
Yes, the death rate is also steadily decreasing. I think it's decreased 35% in the last week.
But this is what I think is for the first time, I don't want to be too cynical about it, but for maybe the first time in this whole epidemic, CDC really got something right. This new system that they have, where they have a relatively high cutoff level on cases, but what they really focus on is the demonstrated hospitalization rate, which is the stand-in for impact on people, and then the percentage of beds occupied by COVID, which is the stand-in for impact on the healthcare system. So by using this to develop their green, yellow, red system, they are really trying to change the way that people look at COVID from just counting every case and worrying that every case could be a death, which is not the case, to only really worrying about the severity and the impact. And that's what we need to be thinking about. One statistic I think is kind of interesting is that there are a billion cases of upper respiratory viral infections in the U.S. every year. 500 million of those are human rhinovirus. And the human rhinovirus, while it doesn't in and of itself hospitalize or kill people, the nature of the virus is that it sets up other tissues in the human body for bacterial infections. So many people, they get sinusitis or they get ear infections or they get pneumonia after having the human rhinovirus. And that does hospitalize and kill people. But you don't work your whole life around how you're going to react to people having colds. And I think that that's the direction that we're going to start moving to with COVID.
The one difference here, rhinovirus is quite contagious, but nothing like COVID-19. The SARS-CoV-2, particularly this BA2, is one of the most infectious agents we've ever had. So it's likely to spread fairly quickly. And the one danger is we worry about those that are immunocompromised and those that are elderly, but that will show up in hospitalizations. And the hospitalizations delay about a week, but that is sufficiently rapid indicator to be used as the primary decision as to whether we change our infectious disease spread prevention practices. So I do approve of the CDC approach as well.
Is one of the reasons that we're becoming aware of everyone being sick is because everybody is testing these days. And obviously the government is providing a fair amount of free testing services to people. And is this a practice that makes sense? Should we keep testing? Is this causing undue alarm? Is this something that should be integrated into a corporate health safety program? What's your view on not only whether we should test, but how often? What are the guidelines here?
My thought on this is that as the incidence rate is dropping, and as we just talked about, it's hard to put a number on it because it's not true anymore anyway. But maybe if you want to put a number on it, say when you're down in the single digits, if you have a screening program where you were just randomly testing people, you're starting to get to the point where your chance of a false positive is probably going to exceed your chance of a true positive if you are, in fact, just doing random screening. However, if what you're testing is people who come in with typical symptoms and you're testing them in order to minimize the spread of COVID-19 in the workplace, that's a different story. And that to me is a reasonable thing to continue to do. But I at this point don't think that random testing makes a lot of sense.
Yeah, I agree with Bill. There are likely to be some asymptomatic individuals, but in general, you really don't want people who are symptomatic in the workplace. And so that a home test before coming in, if you have symptoms, and monitoring your body temperature is certainly one of the earlier, fever is one of the earlier manifestations of the disease, as well as rhinitis and feeling, most people feel a very significant fatigue, and they know something's up. And talking to friends that have picked up the BA2, they felt pretty horrible pretty quickly. So those are the people that we do want to test. And one problem is if someone comes in just pre-symptomatic and are developing symptoms while at work, there could be a super spreader event at work. And then you would have a large number of people out at one time. And that's one of the big concerns. We would hope to prevent super spreader events within the workplace. And I think it's important if the workplace has not done so already, really work on improving the ventilation, the air exchange in your offices so that the aerosol can't build up and the spread will be reduced.
I think that's a real important point, that with all of these things, we're not at the point where anybody, any organization, any person should be saying, okay, we're done. We're just going to go back to the way we were in summer of 2019. That's not it. We still have this layered approach, the Swiss cheese approach. And while we may be pulling off individual layers of mitigation, taking off some of these Swiss cheese pieces, we're not going to take them all off. In fact, I would hope that some of these remain forever, at least during cold and flu season. Things like good ventilation systems, possibly even in more dense or not well ventilated areas, having the air filtration devices. Emphasizing the importance of not coming to work with upper respiratory symptoms. That's not just COVID, but we don't want people coming into work with rhinoviruses. We don't want people coming into work with flu. And this coming flu season, there's a lot of people out there who are saying that this has the potential of being a high flu, a dangerous flu season. And one of the hints towards that is the fact that we are just now finishing a significant and off-season hospitalization peak for flu. So I think that we need to be thinking about maintaining these layers, maintaining the attitude that respiratory infections can be reduced if organizations and individuals take the right actions.
So what I'm hearing from both of you is a theme that you've been a proponent of, which is common sense and recognizing that everybody is attuned to respiratory infections now as a result of COVID and its variants. You seem to be suggesting the following, which is that when people have symptoms, they should be testing, not going into the workplace, carrying things. And Fred, you raised the issue today. Workplaces have to be more thoughtful about respiratory illnesses and how to prevent it, and that means better air filtration systems, and obviously, making a variety of, we'll call it hygiene products available to people. Common sense, such as washing one's hands and with a certain degree of frequency, and obviously, if people are feeling a little bit under the weather, the availability of masks to potentially protect themselves and others. And so I'm suggesting maybe coming out of this period a rethink about health and safety in the workplace and some very common sense and relatively easy steps that can be taken to minimize the risks of infection. Is that a reasonable summary of sort of your current thinking?
Yes, David, that was a really good summary. I agree with everything you said.
Yeah, me too. And David, the one other thing I'd like to add is that as I've been working with organizations, I've come up with kind of a four-part paradigm as to when you're thinking about what you need to be doing. And one is the top layer is you've got to comply with regulations. We had lots of them during COVID, but there are going to be some long-term regulations on workplace air quality and things like that. So that's the first layer. The second layer is thinking of things through the lens of what do you need to do to maintain productivity and operational effectiveness of the organization. The third is what do you need to do to make your employees, your colleagues, feel that you're caring about them, and hopefully because you actually do care about them, but at least they need to perceive that you care about them, because that's going to affect productivity also. But that's the third lens. And then the fourth lens is what do you need to do to be good corporate citizens? You're in the community. You don't want to be doing things that is going to be increasing infection rates or what have you outside of the workplace. So what do you need to do to be good corporate citizens? And I think those four lenses are an important way to think through what you need to do when you're putting in various types of mitigation.
I think that's great, and something that you guys have pointed out. There are different legs to the stool here. Obviously, people understand the issues being, we'll call it biological, but it's also psychological. And could I add a fifth layer to your paradigm, Bill? Don't make it political. Let me shift because since we last convened, there have been developments about the issue of getting another booster, and would love to get your thoughts. And again, I know it's not one size fits all. There is also, there's debate back and forth as there was about the, originally taking the vaccine. But maybe you can unwrap this, but how should people as individuals, as family members, as employers, as fellow employees be thinking about the question of getting an additional booster?
Well, I think one of the things that's very interesting with this is if you look at the terminology that CDC and FDA have used, primarily CDC. Normally what happens is the FDA authorizes, and then CDC, through the Advisory Committee on Immunization Practices and then the signature of the director, they make recommendations. And that's exactly what they did with the first two shots, or the one shot for J&J, but the first series and then the second booster. They made a very positive recommendation. Here's who should get the vaccine, and they laid that all out. Well, now this latest one, they actually very, very specifically said, we are not making a recommendation, we are making it available. So they did not make a recommendation. And and over the subsequent 2 weeks since they made that availability non-recommendation, you've seen a lot of people that are talking about, for the average healthy youngish, I still consider myself youngish, person that may be a booster right now as we're coming into the spring, as we're, there are going to be other pressures that are pushing down the rates. Maybe, and it's not serious, maybe we don't need a booster right now. That doesn't mean we won't need one later, and I'm still keeping a very open mind about a booster in the fall, in order not to have another outbreak come fall. But it's still, that's too far in the future. But clearly, at the same time, there are people who do need to get a booster. People who are older, people who have multiple risk factors, they need to be thinking about getting a booster, because even though they may be protected, unless they're immunodeficient, they may be protected against some degree of serious disease and death. The fact is, if they are at risk, getting even a bad cold can set the stage for development of more serious diseases. So in that sense, I do encourage people who have risk factors, are at the extremes of age, it's not a bad idea to get a booster.
One of the issues is the timing. If right now, when there's such a low level, do you want to remember probably the booster's going to help you for about 6 months? So do you want to do it now, or you don't want to? In Florida, may want to wait a little bit longer, because their experience is July, August seems to be a big peak in Florida because everybody goes inside. That's our winter because it's so hot out. So maybe you want to wait to decide when you want your maximum protection. Now, another issue that's been raised is called OAS, it's called original antigenic sin. And I hadn't heard about this, but I read about it very recently. And it's the concept that if you immunize too much with the same antigen, theoretically you might impair the host's ability to respond to new viral strains. And this issue has been raised by pediatricians predominantly. And to date, there's no evidence that if you get more boosters, your immune system will become less flexible and less able to change to adapt to new variants. So I think that is not a concern, but there is a concern that your immunity will wane over time, and at the time you need your peak antibody levels and cell-mediated immunity, you may not have it because you got the booster too early. So that's part of the timing, and I don't have an answer right now. I'm holding off because I'm a little bit older. I'm holding off on another booster because right now in Florida, the level is so low. And I'm being very careful still in public places. I'm still wearing a mask because I know I'm not as well protected as some others. So that's been my solution. And I think each person has to take, the risk benefit of the booster now versus later.
Well, apropos of that, because we've had more time together, data on efficacy and safety, in terms of weighing the risks and the benefits, is there any new perspective that you have on this? What can you tell the members of our audience?
This is actually, Fred, I'll be very interested to hear your thoughts on this. An article I read from, not from in a pop magazine, but it was actually a scientific article, was saying that given that we will likely have a more tailored, more Omicron-specific, more current vaccine in the fall. And the FDA they're discussing that with the manufacturers right now. But given that, there is some concern that if you are too recently boosted with the current vaccine, that if you get this enhanced vaccine, this more tailored vaccine, that your immune system will attack the antigen so fast that you won't really develop adequate immunity to this new antigen that you're given, and it won't have any great benefit to you for protecting you from Omicron. So that's another reason why I'm thinking that I'm probably, since we don't have our winter in the summer as you do in Florida, I'm probably going to wait until the fall and get boosted in the fall.
Yeah, Bill, that's a really important point about the Omicron-specific boosters. Are they going to be a benefit? And the early evidence is they aren't any much better than the original vaccine. And I think the reason that may be the reason that you're attacking that antigen and it's being eliminated from your system so quickly that you don't generate as good an antibody response to that particular specific antigen. So I don't know. I think the evidence is coming in, but it may be that having the more tailored vaccine will not be that much better than the original vaccine. But I think we've got to wait for the studies to decide that.
Okay, and final question from people who are returning to work. They're concerned about their kids. Kids are in school, spring break. Fred, the term super spreader event, I'm thinking anytime people get together in groups of more than 10, a potential super spreader event. I don't know if that's your definition. So any common sense guidelines?
Well, I think vaccination is very important for children because they are gathering in large groups and they are at risk for more super spreader events and can then transmit the virus to those that are elderly in the family. So I would encourage vaccination. We vaccinate for other diseases, and I keep hearing now, are we in the endemic phase or the pandemic phase? I think, endemic means it's here for permanently. And this virus is going to be here forever. So I think it's time to acknowledge that this isn't going away. And the best tool for any endemic disease is vaccination. So I really think we should encourage parents to get their children vaccinated. Bill, your thoughts?
And I agree completely. And then the other part of it for businesses is what we talked about just a few minutes ago. You don't just say, let's go back to summer of 2019. We're going to leave in place some of these layers of the Swiss cheese, and individuals need to do that also. You don't throw yourself into the crowded bar where everyone's shoulder to shoulder and yelling at each other in the bar. That's going to be a high risk environment. But if your kid's going to school, the classrooms are not dangerous. It's more of the social activities where they're going to have higher risk of transmission. But when we say dangerous, there's a danger of getting COVID. They're not at high danger of getting sick. So we just have to keep in mind that this is a different virus, a different environment than it was even just a year ago.
All right. Once again, guys, thank you not only for the wisdom, but the plain speak around this.
Oh, very much so.
Absolutely,
All right.
David. Mental flexibility and willingness to take in new data and change behavior is critical for all infectious diseases.
On that note, look forward to our next session in about 2 weeks. Take
All
care.
right.
Thank you, David.
Take care, David.
Thank you, guys. Bye-bye.
Dr. Bill Lang is an expert in public health responses to biological incidents, including pandemics. Dr. Fred Southwick is an infectious disease specialist at the University of Florida College of Medicine. Both doctors are part of the RANE Expert Network. Individuals and organizations turn to RANE for risk intelligence that cuts through the hype to focus on what they need to know, what to expect, and what to do. Sign up for our coronavirus solution. Visit us at ranenetwork.com. That's RANE network.com. I'm Emily Donahue. Thanks for listening.